reminders. What do you call it?
Yes, right. They'll post it.
Okay, so we are on the main platform.
Vanessa,
Hi,
we're waiting
Rocky.
for your
Hi,
instruction.
Nisha.
Afro, Afro, whoa. Yalela, 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 yalela. Yalela, 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 yalela.
Okay. Hello everyone. We are going to start our webinars shortly. Before that, you can see the slide about the sort of housekeeping rules. So we need to follow up these as you see in the slide. And I'm really excited to start this webinar. And hello and good afternoon to all. Good afternoon, good evening, or good morning to all. My name is Sita Sahi. I'm the regional coordinator of ICW Asia Pacific based in Bangkok. On behalf of ICWAP, along with the 7 Alliance, I would like to welcome you all in this second series of cross-learning webinar on the CLM that is entitled Meaningful Engagement of Key Populations, Community in Developing a Community-Led Monitoring Indicators Related to Structural and Social Issues that affecting health services. So ICWAP, together with the 7 Alliance, we would like to acknowledge our guest speakers who come from grassroots communities, participants, donors, and other allies, including team of our regional networks, for participating in today's webinar. Thank you so much for CDC and UNAIDS for providing this support to 7 Alliance for the CLM activities. I would like to give you very little background of the beginning of these webinars. So initially, our first series of webinars were kicked off in May, that is 15 and 16, in which one was led by APCOM on capacity building, such as basic concept of CLM, its principle and steps for implementation, whereas ICWAP-led webinar was focused on meaningful engagement of key populations. In setting up the implementation of CLM programs, strategies of negotiation with their funders and agencies to own their exercise. So consequently, we came up with this objective of the 2 days webinar, and all cross-learning webinars are framed as a meaningful engagement of key populations and community in the CLM. So the first one, the objective is community leaders to share their knowledge, resources, and information about the importance role of community in leading and deciding on the development of the indicators that measures stigma and discrimination, barriers to sexual and reproductive health and rights, and others other forms of social inequalities. The second one is community to identify key asks for meaningful engagement in the development of these CLM indicators and specific structural and social barriers affecting health services that need to be included in CLM programs. We will be hearing practical and lived experiences from our panelists, and there will be the room for open discussion as well. Furthermore, we also need to analyze that how comprehensive indicators are developed to respond to the existing social and structural barriers and gender inequalities. We also want to know more about, do we have a room to discuss these issues, as I mentioned earlier on the CLM, as well as whether we have resources to addressing these areas. As we know, the gender inequalities and violence against women are very much interlinked and associated to HIV infection and retention. For our community, structural and social issues are the elephant in the room. Social inequalities drives HIV infection and affects our community in accessing and uptake of the health services. We know CLM is not one time off, but routing, monitor, and tracking is required. And most importantly, monitoring pressing issues, very pressing issues on the perspective of gender lens, which are overlooked, and how we put resources to have greater outcome in critical discoursement as well. This is really important to think about. And lastly, let us think about, are we doing right thing? As I also said same thing in the previous webinar. If not, what need to be done and how CLM can be leveraged in addressing barriers to accessing SRHR and responding violence against women. Thank you so much. And I will stop here my remarks. And now I would like to, without further ado, I would like to invite our first speakers to Dominic McKim. I'm sorry if I'm pronouncing wrong. Community advisor from UNAIDS headquarters, to highlight the ideas on how to generate the ideas on to address social inequalities through CLM, including gender inequalities and gender-based violence. And the floor is with you, Dominic. Thank you.
Thank you, Sita. Thank you. Thank you for that lovely introduction, and also the background and context. Hopefully, I'm able to build on that. I think my first statement, or my first takeaway for everybody here is, so welcome, and it's great to be here. My name is Dominic Kemps. As Sita mentioned, I work in the community engagement team at UNAIDS, and I'm the CLM technical lead. And I was really excited when I was asked to present today. And then Michaela and the team, Sita, asked, oh, can you provide a gender lens on this? And so I was like, oh God, yeah, yeah. Let me see, because gender is actually at the heart of a lot of CLM monitoring, right? So it's kind of embedded in a lot of the programs. If you look at who's being spoken to and some of the issues that are being addressed, the problem is that we don't always break out data particularly well to understand, if you want to take a gender lens in terms of who said what. We're reporting overall numbers sometimes, and this came up in a meeting very recently, actually in Johannesburg, where we had 16 countries from Southern Africa together, and we had a long discussion about the fact that the programs are actually showing great results across a whole range of indicators, and sometimes our reporting on what's actually being delivered is a bit humble. We're not actually giving all the detail. And so whether it's the breakdown of the diversity of the community monitors and the representation of all key populations in those monitors, or whether it's what it means when you're monitoring sexually reproductive health services instead of just monitoring or just reporting on kind of commodities, can we get some more of the detail on actually some of the conversations and the why? A lot of that data exists. It's just not always reported very freely. So I'm going to try and do my best today to very quickly give you a background on CLM, because I understand it's a bit of a mixed audience in terms of experience. And then I've got a couple of slides at the end, which is really going to focus on some experiences, that I've been able to draw out of some of the reports and other conversations and findings that we've seen recently. So why inequalities? Well, inequalities are at the heart of the UNAIDS strategy and the political declaration that kind of is our guiding principles for the next well, this decade basically. And at the heart of that political declaration is both this focus on inequalities, but also communities and the focus on communities. And you've got these three targets around testing and treatment, around prevention services, and also societal enablers. And these are supposed to be explicit opportunities for communities to lead the way, not just because it's about an act of altruism in terms of creating that space, but because communities are best placed to actually address those issues. So the first thing, and I start off all my presentations on CLM is that when we refer to community-led, we're speaking about community-led organizations, right? So PLHIV and KP groups in all of their diversity. We're not referring so much to community-based organizations. And I know to this audience, I think this is well understood, but I have it there. And what we mean by community-led organizations, because sometimes it's not really clear, right, is that the majority of the governance staff, spokespeople, membership are reflect the experiences of the community they're trying to serve, their constituencies, and there are transparent mechanisms of accountability back to those communities. So again, community-led organization is a catch-all, and sometimes we forget who that might be included. So we might forget that it includes youth-led organizations, women-led organizations, PLHIV groups, but also, again, KP-led organizations we must remember is representative of multiple communities, right? It's not a single population. I know you know all this, but it's just really important when we talk about, we've got KP engagement. Yeah, is it really are all key populations really engaged in CLM, or is it just an MSM group or a female sex worker group? Those are the things that we're trying to sense check to make sure that as we're building capacity over time, that we're having truly diverse CLM programs that are led by communities in all their diversity. So what is community-led monitoring? Again, I think many of you will know this. I think some of you may be less familiar, but in UNAIDS parlance, we talk about it as an accountability mechanism for national HIV responses. It's led by PLHIV groups and networks of key populations and other affected groups. It's a structured platform, as Sita mentioned. It's ongoing. People are trained systematically, capacity built to actually undertake and lead this work. We encourage, obviously, people leading this work to be reimbursed as well. This is not an act of voluntarism. And this data is used for monitoring trends along the HIV care cascade to inform targeted action that improve quality of services. Now, I say HIV care cascade here, but I just want to make really clear, CLM can be used broadly, right, for almost any health intervention. I'll talk to you a little bit about SRH results in a minute, but it could be used for non-communicable diseases, human rights violations, etc. The important thing is that the priorities are set by the communities that are being monitored, right? So it is communities are defining, this is what needs to be monitored, this is where the failing is, this is what we want to see action around. The life cycle, again, many of you will be very familiar with this, but it's about identifying, obviously, a set of issues, again, from the grassroots up, collecting information, analyzing and interpreting it, disseminating that information, advocating for solutions, and monitoring the change. Now, the key thing here is that I think on the right side of that circle, I think generally programs right now are doing quite well. So this is that kind of beigey block at the top and the green ones. We're seeing lots of programs that have good data collection and are disseminating data reasonably well. And we're actually seeing feedback mechanisms into clinics and other duty bearers working quite well at a local level. Where we're still seeing a struggle to really drive change is how those results then at a national level feed into national change. But we also know advocacy takes time. So, it may also be a function of time. These are some examples in terms of positive results as a result of community-led activity. So not just CLM, but all community-led responses. But I would say that any number of these things, all of these things could be monitored by CLM. And that's why I've included it. So everything from obviously knowledge, but also quality, access, linkage to care, and then, you know, things like stockouts and coverage and exclusionary practices are really big topic in CLM programs. So some examples, and I've tried to really frame these examples in the context of this session around SRH, gender issues, inequalities. So I'm afraid that a lot of the examples are from Africa, because that's where we've got the most documented evidence. But I'm really excited that as a result of the work that you will all be undertaking, that in a future presentation, hopefully I'll be using more Asian examples. But here we've got from Malawi monitoring the provision of cervical cancer screening and treatment. And you can see that roughly 90% of clinics in the catchment area are doing screening, and 66% are providing treatment. You can also see that about 25 out of 30 clinics are actually integrating HIV and cancer services for women. And you can see here just an example from one clinic in Mikolongwe, where you can see the number of clients increasing month on month from about 10 to 80 in terms of, for this is cervical cancer screening. Also in that program, Lula2, which is the name of the CLM program in Malawi, you can see that they're monitoring both male and female condom availability, so both quantities. And again, obviously, often we see just condoms being monitored in terms of stockouts, and without the distinction between male or female. And so again, an example of just a small detail making a big difference in terms of what we're able to report, what we're able to understand. And in Kyrgyzstan, this is some data actually just received in the last few days. This is following kind of a mystery shop kind of exercise, and basically they found that LGBT communities accessing services didn't actually see systematic discrimination. You know, 77% plus of people said that the services that they received were satisfactory. And actually the last bit of those paragraphs there, 5.8% of secret clients, so this is mystery clients, secret clients is the language they use in that part of the world, were a bit confused, said that medical professionals were a bit confused when they came out in terms of their sexual identity. And I think that was quite actually interesting, that number was, I mean, in some ways you might say it's low, but in some ways I think that's actually quite high for a medical professional. But also sadly, we do see individual cases here of medical specialists showing interest and flirting, you know, being unprofessional with key populations when attending services. In West Africa, just an example here in terms of, again, the increase in new initiations, treatment initiations with key populations, MSM, sex workers, people who use drugs. And as I understand it, it's primarily MSM and sex workers, you know, from 63 in the first 6 months of the project to over 1,000 in the last 6 month reporting cycle. And from Papua New Guinea, a little bit closer to where you guys will all be based, you know, the KPAC program there is able to identify specific clinics where discrimination is being recorded against individuals. And what that allows you to do then is you're able to work with the clinic, because you've got data to show that actually your clients are systematically facing discrimination when they come into your services. South Africa, very similar example in terms of you know,
Sorry,
recording.
Dominic, can you please wrap up, because
yeah, this is my second to last slide.
Thank you.
Yeah. No, and so in South Africa, very similar data around accessing of services, again, for key populations. And the idea here though is that, and I encourage you to go to Ruchitse, the program website. It's got dashboards that you can actually break down that data, and they actually can do some of the inequalities / gender and sexual reproductive health lenses that you're looking at or thinking about today in their reporting. So, you know, there are some examples out there, but what I would encourage is that, you know, this discussion leads to more of this in your programs, that you're thinking about when you're collecting your data and analyzing it, is making sure that you are able to break down, you know, to really understand inequalities, but really look at SRH, but also gender issues, as is the focus of the discussion today. Anyway, sorry, that's a whirlwind tour. I hope that's helpful. And I'm always available at the email here if you have any questions or would like to discuss further. Thank you.
Thank you so much, Dom, for your great insight and a lot of learning from other countries as well, who are amplifying the work on CLM and including gender aspect as well. Thank you so much, and we look forward to your presentation as well. We haven't received in our email, so that we can share with everyone. Thank you so much once again. And now I would like to sorry. Sorry, can you please mute yourself so that it would be easy to hear for everyone if you are not speaking to. So thank you, everyone. And now I would like to invite and hand over program to our very beautiful, strong moderator. We know her. And from last webinar, we also lot of energy put into the last webinar as well. So it's really encouraging. And says Ren Cortez, Senior Program Officer from Community Right and Gender, CRG at the Global Fund. And we have the co-moderator as well, Sarah Thapa. But before that, I really would like to give the all platform to you, Ren, and welcome you. Thank you.
Good morning and good afternoon to everyone. Thank you, Sita. So, my God, I got so thinking with having the energy. So I made sure I had coffee to make sure I'm all alive for you for moderating this session. So thank you again for asking me to moderate your series of CLM webinar series. As mentioned already in the introduction, this is already the second of the cross-learning, but it's the fourth of the series of the CLM webinar series. And thank you, Dom, as well from UNAIDS, to providing us that whirlwind tour and bringing us back about the concept of CLM and how it is working into different parts of the world as well and in globally. So in this session, as you can see in the title of the session, it's going to be focusing, if you remember the CLM cycle, we know that there is the cycle wherein we are developing indicators. So this specific webinar will be talking all about developing community-led monitoring indicators and going beyond just, for example, standard HIV indicators, but also looking at structural social issues that are affecting access to health services and even HIV. And we actually have 3 important speakers that will be sharing to us today. Just a few reminders as well, so that we make sure that the flow goes as well. Can we quickly pause and show again the housekeeping rules, just to everyone to be reminded, if Upcom team can help us show that quick housekeeping rules as well. So please note that this session is being recorded for cross-learning and learning purposes, and that this webinar is going to be provided in English. So we do not have currently available translations. Make sure to, in your profile, put your name, organization in your country, or you can even type it in the chat box. Please make sure that you are muted at all times, and you are able to unmute if you are asked to share or to speak as well. We have 1 hour and a half of a moderated discussion, which will also include Q&A. So feel free to not only ask or type your questions on the chat box, but also ask them questions if you feel sharing or talking about them. And if possible, if you feel comfortable, please turn on your video as well. So we're going to go directly to our moderated discussion. I would like you to introduce 3 speakers that we have. The first speaker that we have is Nisha Rongram. is a Thai transgender woman who currently serves as the project manager of the Asia Pacific Transgender Network. She has a strong commitment to promoting human rights, health, and HIV programs for transgender individuals in Asia Pacific. And in January in 2022, her organization APTN has led and developed the TransComp or Competency Community-Based Monitoring Tool. And this has been piloted in several countries in measuring AAQ of health services, including SRHR and gender-affirming care, mental health, and general health care. The second speaker that we have is Rocky Rinabor. Rocky is a gender and development specialist, a human rights educator and an activist working particularly on SRHR, women's rights, LGBTQI rights, indigenous people's rights, and the rights of refugees and internally displaced persons. So Rocky is currently the project manager of the Community-Led Monitoring System, or CLMS, in the Philippines, and that is currently being developed and implemented by TLF Share with support from PEPFAR, USAID, UNAIDS, DFAT, and Achieve. The third, but not the least of the speakers, of course, is Adelia. Adelia is a female sex worker since 2005. She works as an advocacy staff at the Indonesian Social Change Organization. Currently, OPSI, together with 7 national networks, are training members to become CLM focal points who will monitor health services, advocate for policies, and encourage change and improvement of services according to the needs of KP communities. So let's give all a welcome to our 3 speakers that we have for today, who will be sharing their experience in their CLM programs in their respective countries or region, and talk specifically about indicator development and how communities are involved. So for all our speakers, I would just like you to start perhaps with sharing. When you were developing your CLM mechanisms and you are at the stage or developing CLM indicators, what was the opportunity or what was the step you were taking to ensure that there is community engagement in developing your indicators? And at the same time, maybe we can provide also some examples of what CLM indicators you focus on and how or what is the process in developing those indicators. So maybe we can start with Nisha.
Yeah, thank you so much, Rain. And hello, everyone from I'm Nisha from APTN. I'm based in Bangkok. So at APTN, as Rain mentioned previously, that APTN has piloted our 6 TransCom CBM tools, which is considered as a CLM tools at APTN. So we have been piloting the TransCom CBM tools in 7 countries in the past 2 years and 3 countries in this year. Yeah, so at the beginning of the TransCom CBM tools, we actually has like the framework 20 to develop it. We have like a 21 steps framework of the development of the tools, and at every step we ensure that we have the engagement with our trans community in the region. So from developing the tools, from provide them a training, analyzing, and disseminate the information that we obtain from the piloting activities. So every step we need to ensure that we have the engagement with the trans community in Asian Pacific. And our TransCom CBM tool, we use, I think, similar to others CLM tool, we use AAQ framework to develop our TransCom CBM tools. And I think it's kind of like, cover all of the key indicators that we've been discussing, gender sensitive, gender inequality, or S&D, but to myself, I think that during implementation or analysis, I think 2 indicators that it's outstanding, or it's shown clearly than other indicators are the gender inequality and stigma and discrimination, because of we're not just piloting the tools, but we also have like a reflection session with our transgender clients who went to the clinic and received the service. And yeah, we also do like, you know, interview to get their reflection from the services. So the two main issues that we obtained from the reflection session is you know, the gender inequality and stigma and discrimination. So yeah, actually from the framework that we used, yeah, two indicators that I personally think that we can, you know, address, or we can learn more from our Transcom CRM to us, the gender inequality and SND. So that's from APTN.
Thanks, Nisha, for an overview of how USR Regional Network is developing a regional tool that is being rolled out in other countries, and the expansion beyond HIV and covering other health services. So maybe later on, we can expound more on that later on when I come back to you. So let's give the floor maybe to Rocky Rinabor from TLF Share to also share the experience in the Philippines, especially indicator development. Rocky?
Thank you, Rain. So during the development phase or process of our indicators, we were very particular about engaging and consulting different groups of key populations and civil society organizations advocating for SRHR in the Philippines. And it was very clear to us that it's the community of KPs who should have a final say on what should our monitoring indicators should look like. So established an interim consortium, which is composed of different groups of key populations. Although I must say that we were not definitely that, you know, the groups are not that exhaustive. We were not that, I must admit, not that inclusive. For example, we were not able to get groups from the PWD community. So those are one of our challenges during the process. But in the Philippines, we monitor different critical areas of the HIV and AIDS response. We call our CLM, we call these CLM pillars as CLM areas as CLM pillars. And they are service quality, stigma and discrimination, policy, and investment. And each of them has its respective indicators. For example, for service quality, what we wanted to monitor is the level of service quality that is being accessed by different clients at the facility level, and the level of satisfaction that they get once they are able to access those services. We also look at whether or not services and commodities are available, accessible, and of course, these services are continued. So just like with APTN, we also anchored our, we also anchored our indicators for service quality on the AAAQ framework. And then for stigma and discrimination, we particularly want to document and monitor prevalent and new cases of stigma and discrimination. We are aware that cases of stigma and discrimination also evolves. In the past, the community experiences it at the facility level. Now, even online, the community also experiences forms of stigma and discrimination. And then for policy, we wanted to make sure, because in the Philippines, there's an HIV and AIDS law, and we wanted to make sure that the law is being, religiously implemented. So we want to see how it is being implemented, how the policies that are required are being done, and whether or not these are being felt at the community level. For finance and investment, of course, we are aware that sometimes the overall allocated budget or investment for HIV and AIDS may not be enough. So we wanted to establish a trend on, or a pattern on, or a baseline on how much really is the investment that's needed to have a better HIV and AIDS response. Thank you.
Thanks, Rocky. I was just thinking if you wanted to add more, but that's already very comprehensive. Many CLM system only focuses usually on a certain aspect, but definitely your working group, if I may say, in the Philippines, has thought about it to include different pillars of not only service quality but also like policy, S&D, and resource monitoring as well, which is comprehensive enough. Let's give the floor now to Adalia from OPSI to share the experience from Indonesia. Adalia? Can you unmute? Yeah.
Selamat siang, sore untuk semua teman-teman dari. Saya Adelia dari.
Sorry, I'm Ika. I will be the translator for Adele for this session. So good afternoon for the participant. My name is Adele. Kak Adele.
Mohon maaf, Kak Ika tadi nanya apa?
Bagaimana bisa nggak jelasin bagaimana opsi memastikan keterlibatan komunitas dalam pengembangan indikator CLM di Indonesia?
Oke, sebelumnya mungkin saya mau menceritakan kalau CLM di Indonesia itu sudah ada sejak tahun 2018 ya, ada CBMFO. 2018.
So the CLM Indonesia is already exists since 2018.
Terus di tahun 2020 ada CLM Jarnas. Jadi ada 7 organisasi nasional berbasis komunitas, ada pekerja seks, menasun, orang yang hidup dengan HIV.
Ini dibiayai sama siapa, Kak?
Itu kalau yang Jarnas itu sama UNAIDS kalau nggak salah.
Okay, so in 2020, the UNAIDS support the CLM for the national network. 2022. Oh, sorry, 2022. The UNAIDS UNAIDS Indonesia supported the national network of key population to do the CLM. So the national network consists of the sex worker community, people living with HIV, gay men community, transgender, siapa lagi Kak?
Inti muda,
young key population, and also people who use drugs.
Bagaimana cara kami memastikan keterlibatan komunitas dalam pengembangan indikator CLM adalah kemudian dari awal kami memastikan isu-isu yang kami dapatkan tentang kebutuhan itu langsung dari teman-teman komunitas sendiri.
Okay, so how we ensure the engagement of key population in the CLM indicator development is we make sure to engage all the community since the developments, like to consult with them as our member. Apalagi Kak?
Lalu di situ juga ada kayak peningkatan kapasitas, terus kita juga kayak kasih informasi tentang apa itu CLM dan kenapa mereka harus terlibat gitu. Karena
and also the capacity building for them to understand what is the CLM and why it's important for the community. Because karena
mereka atau teman-teman yang akan bisa langsung memantau dan menginformasikan gitu pada kami gitu untuk kayak ada database, ada informasi tentang kekerasan. Jadi itu kemudian nanti kita jadikan kayak bahan advokasi yang itu yang langsung disampaikan karena biasanya kalau bukan komunitas mereka akan enggan untuk membuat pelaporan.
Okay, yeah, because the community in the provincial level they are the lead. They must be the lead of the CLM, so they can give the inputs or the database to the national network to become the advocacy tools to the government to make change of the system.
Ya, modul pengembangan untuk CLM juga itu juga melibatkan kebutuhan gitu ya. Jadi nggak langsung dibuat, tapi mengacu pada kebutuhan gitu. Apa sih yang mau kita lakukan bersama gitu? Apa sih kebutuhan komunitas? Jadi bukan by project, tapi by kebutuhan. Jadi harus benar-benar teman-teman yang kemudian terlibat untuk membuat modul bahkan panduan kita bikin sendiri komunitas.
Yang bikin ini jaringannya ya, jaringan nasional. Okay, so the national network of key population, they developed the CLM module to be used for their members in the provincial level to understand the CLM based on the first consultation and what the needs of the community of the CLM knowledge as well.
Jadi di tahun 2022 itu bahkan peneliti, enum gitu, semua itu basicnya itu dari komunitas itu sendiri, itu perwakilan Janas.
Oke, ntar dulu Kak, research-nya ini di bidang apa?
Di situ kita ada melakukan pemantauan untuk pelayanan kesehatan, kekerasan gitu.
Okay, so they also did the research on the situational analysis on the HIV services in Indonesia based on the needs or the inputs from the community as well.
Sebenarnya CLM di Indonesia itu punya 10 indikator ya untuk itu, tapi kami memastikan kami ada 10 indikator, tapi kami ambil satu indikator yang kemudian kami berfokus pada kualitas layanan gitu, memantau kualitas layanan yang diterima oleh komunitas, termasuk ketersediaan obat, kualitas layanan kesehatan, dan kepuasan pasien. Jadi itu yang saat ini lagi dilakukan.
Okay, so currently in Indonesia they have like 10 indicator, but they now more focus on the one indicator only, which is the quality of the HIV services. It's including the stockout ERV report, and also the satisfactory of the client.
Itu aja juga kemarin untuk focal point, saat ini sudah ada focal point di 20 distrik itu, 14 distrik, ada sekitar 20 distrik itu mereka sudah punya focal point untuk CLM. Kemarin sudah ada pelatihannya dan saat ini sedang persiapan daerah.
20 ada focal point di 20 distrik yang sudah dilatih gitu. Suara Kak Adel putus-putus.
Iya, ada 20. Jadi dari 7 Jarnas itu kami kasih perwakilan 2 untuk focal point yang dilatih. Jadi ada 20-an distrik ya kemarin itu yang kemudian akan ada focal point yang sudah mau pelaksanaan di awal Juli ini untuk pemantauan CLM.
Okay, so based on the consultation with the 7 national organization, there will be having like 20 district focus, and in those district they will having each focal point that who did the CLM in more in depth.
Ya, jadi kami benar-benar memastikan bahwa isunya dari komunitas, CLM-nya komunitas, juga nanti advokasi yang dilakukan itu sesuai dengan kebutuhannya komunitas.
Okay, so with this we want to really ensuring that the CLM is community lead, and they will so we can have the data based on that, and how we can engage the community in the process. That's it. Thank you, Ren.
Terima kasih, Adelia. Thank you for sharing the experience of Indonesia, especially combining all these 7 or 8 networks working together to ensure comprehensiveness in including all different key populations, and even a model that is making sure that it reaches to the district, not only into the center, which is very important in developing your CLM mechanism. Thanks. I think we have a good example that's being shown here. Like we have examples from different key populations. We have a specific one from trans populations that in developing indicators. And what is recurring among all these experiences from the three speakers was the concept of consultation, the meaningful consultation and engagement of key populations, especially in indicator development, which is very important as well. So maybe we can tackle very specific indicators for each of them that maybe they can expound more. Maybe a question for Nisha is, my question is, how did you decide, because gender affirming healthcare services is expansive. It covers a lot of services. How did you then decide which of those services should be measured and should be monitored, especially important for trans people?
Yeah, thank you, Rain. So actually, our Transcom CBM2 is supported by the HIV program, right? But actually, we we always be aware that the important SRHR of the transgender people or transgender community in the region is not just the HIV or the STI. So that's why we expand our Transcom CBM2 into the gender affirming health package as well, which is, you know, the hormone monitoring or the gender affirming surgery, you know, kind of like, you know, giving them the consultation, you know, at the clinic. So that's why we expand those gender affirming healthcare services into our CBM2 as well. And to address your question, is yeah, we of course do the community consultation to develop our Transcom CBM2 to ensure that which is the fundamental or essential for the trans community in the region. And because of many countries in the regions now, we don't have gender recognition law, so we still recognize as a gender, you know, assigned birth, so that the gender affirming is not listed on the social welfare package. So that's why we would like to include this gender affirming health care into our CBM2, because we can take the information or the data obtained from the CBM activity to advocate with our policymaker or our government to see how essential or necessary of this gender affirming healthcare for the transgender people. So yeah, we got the information from our trans community, you know, across the region, and we use the data obtained from the activity to advocate with our government. Thanks.
Thanks, Nisha. I think what is very important, especially for using CLM in the context of gender affirming healthcare, is it's very contextual, especially in a country who may or may have not have gender recognition law that allows access to gender affirming care services. So this is something important that we need to remember, that the development of indicators varies in different countries, depending on the barriers, legal barriers that is hampering the country. And of course, you apply the indicators that are most relevant to a specific country. And it's not the same for very countries. So maybe we can go to Rocky to share a little bit more. Remember your 4 pillars. I would like to ask more of your SND indicators about stigma and discrimination. And maybe you can share more something about that and some examples as well.
Yeah, sure. So before the development of CLM indicators, we already had a stigma index in the country. There was also a human rights roadmap that was developed under the Philippine National AIDS Council, which actually informed us about different rights-based barriers experienced by different key population groups. So when we started developing our indicators, those 2 documents were some of our references. We used them, but the final decision on whether or not which indicators do we really want to, you know, monitor and do was also based on the community's demand to look at the different stigma and discrimination experiences of different key populations, because we know that there are, each KP has unique experiences in terms of stigma and discrimination. So for example, we wanted to see whether how transgender women, for example, who do not have access to gender affirming care, impacts their access to HIV and AIDS services as well. So our stigma and discrimination indicators are, it has 6 settings. So first we do monitor experiences of SND at the facility level. We do monitor experiences of SND during humanitarian and crisis, even at the home or residences of key populations. We also look at who are the usual perpetrators. Are they partners? Are they service providers? Are they government employees or officials or other service providers outside of the HIV and AIDS? That's why we also look at the experiences of key populations in the educational institutions as far as their actual and perceived HIV status are concerned. So in terms of the specificity of the indicators we look at, of course, we record different backgrounds of demography. We look at who are the usual, because we wanted to establish a baseline on which are the usual acts, discriminatory acts experienced by different key populations. We also wanted to see whether whether there are commonalities. I mean, for sure there are, but we wanted to document which are the common discriminatory acts experienced by these different groups of KPs and which are the unique ones. Yeah, that's it. That is how we, finalize the indicators.
Thanks, Rocky. Indeed, SND is very encompassing, right? And it's good that there's an initial basis, such as the PLHIV stigma index, as a basis to get initial indicators. Of course, the stigma index is a different from CLM, but it's a useful tool or reference to start developing your own indicators for CLM. And I like the point as well that you were trying to include SNE in the context of humanitarian settings. And of course, many CLM mechanisms are being transitioned or expanded to be ready for future pandemics, as we know that SND is heightened during pandemics and epidemics. So that's a very crucial point as well. So Adelia, I would like to go to you, and maybe you can share to us, you mentioned that predominantly OPSI and the national networks focuses generally on service quality, but do you also have examples of indicators on gender-based violence? I know that sex worker is a big group that you are trying to tackle. So maybe you can share any development of indicators related to gender-based violence. And maybe Ika can translate if needed.
Perlu translate, Kak?
Ya,
Iya.
dikit yang belakangan ngerti.
Oke. Tadi kan Kak Adel jelasin bahwa indikator yang utama itu adalah kualitas layanan ya. Tapi apakah dirimu juga punya contoh indikator dengan yang berbasis gender based violence, kekerasan berbasis gender? Karena kan pekerja seks adalah kelompok yang besar ya yang ingin ditangani oleh OPSI. Jadi mungkin Kak Adel bisa jelasin sedikit tentang pengembangan indikator kalau ada yang di gender based violence.
Oke. Jadi sebelumnya karena kami di CLM juga ada database, ada beberapa dari Jaknas ya, ada pelaporan gitu ya. Itu yang kami kemudian gunakan untuk menjadi indikator gitu. Ada beberapa contoh kasus kekerasan seperti misalnya teman pekerja seks yang mengakses layanan KB ya. Kalau layanan KB di Indonesia itu kan dia harus punya pasangan gitu ya. Jadi ketika perempuan pekerja seks tidak menikah, mereka akan kesulitan mengakses layanan KB.
Oh, okay. So the indicator development is based on the inputs from all the networks of key population in Indonesia. So in terms of the gender-based violence, I think Adele give the example when the female sex worker try to access the family planning. The family planning services in the health services when they are not married or when they are younger than 17 years old. So they need to have the partner consent, which is the husband. So if they not have the husband, so those female sex worker cannot apply for the services or certain services.
Sudah. Terus kalau untuk teman-teman ODIF misalnya ya, ini kan kita Jaras itu ada tujuh jaringan nasional yang kemudian menyatukan satu isu. Kalau di perempuan dengan ODIF gitu, perempuan yang hidup dengan HIV gitu, pekerja seks, mereka juga masih ada yang kayak apa itu spiral paksa, itu masih juga.
Assalamualaikum, I'm Pakistan.
Oh, okay.
Can we ask someone to turn off their mic? Thank you. Yes, Adele.
Terus juga kalau yang untuk transpuan, karena opsi itu kan 3 gender ya, laki-laki, perempuan, dan transpuan pekerja seks. Kalau transgender kemarin itu masih ditemukan kayak misalnya menunggu di layanan untuk mendaftar, itu juga jadi masalah karena masih dipanggil nama aslinya gitu, masih ditaruh di belakang, nanti belakangan aja lah dia gitu. Terus masih aneh lah kayak laki-laki milih jadi perempuan gitu. Itu juga masih terjadi.
Okay. So when speaking from the woman living with HIV perspective, a lot of a lot of women living with HIV, they forced to take the spiral because the service provider don't want this woman or the woman living with HIV has more children which will affected by the HIV. So they also can report that. Other than that, this is, I think, the part of the quality of service as well. When transgender women, they come to the healthcare services, they tend to call there by the
Real name.
Their real name or their name. Yeah.
Yes.
Okay, thanks, Adelia. I think you provided very good examples, especially for women living with HIV or women who have sex workers. Exactly what are the barriers for them to access? For example, people who are not married, who doesn't have their husband, are unable to access services. And definitely those are something that can be translated into an indicator for CLM to see if these are persisting issues that hampers access to services, which is very clear. So that's good. I'll try to get some questions first from the chat because there's an earlier comment about the importance of gender and gender disaggregation of data. So maybe that is something that I would ask to the speakers first. How do you incorporate, or do you incorporate gender disaggregated data in even your CLM indicators? And maybe you can provide as well an example of that. Maybe we can start with Rocky this time.
Yeah, thank you. We do disaggregate data on gender. In fact, even our sex assigned at birth, we collect male, female, including intersex. And for gender, we collect data from various under the umbrella of gender. So they are part of the report that we release. Currently, we are piloting with our partner facilities, and whenever we go to them to communicate the results of our data, we make sure that these kinds of data are also disaggregated so they see which particular group of gender, for example, is or are affected by different issues or critical gaps discovered during the data collection.
Thanks, Rocky. How about from Nisha? How do you ensure data disaggregation, especially within the trans maybe umbrella or the population? And how do you ensure and gather that?
Yeah, we actually use the self-determination. Actually, our Transcom CLM tool is used specifically for transgender community in the region, right? But yeah, we also we also believe in the self-determination, because yeah, if someone reported that they are transgender, so we we respect them of what they determine themselves. But yeah, for our Transcom CLM tool, we specifically use for the transgender community based on the self-determination of the clients.
Thanks, Nisha. How about for Indonesia? Adelia, how do you ensure that you're able to get disaggregated data through your CLM indicators?
Kak Adel, gimana memastikan bahwa bisa mendapatkan data disagregasi melalui CLM yang sedang dijalankan?
Jadi kalau di Indonesia kami melakukan pengumpulan data itu langsung dari komunitas lewat penelitian atau survei, juga dari data-data yang dimiliki oleh 7 Jarnas gitu, dari laporan kasus, ada catahu, ada laporan kekerasan harian, ada data dari teman-teman female sex worker, seperti itu pengumpulan datanya.
Kak, di dalam apa namanya, di dalam survei itu ada nggak pertanyaan yang kayak bagaimana caranya tahu gitu ini diambil dari perempuan atau dari laki-laki atau gimana?
Jadi kami memisahkan data ya, jadi masing-masing Jarnas itu kami punya data sendiri kayak, jadi ada gender, ada usia, ada kelompok gitu kan. Kayak misalnya pekerja seks datanya sendiri itu dipastikan sendiri gitu. Jadi enumnya untuk yang ambil kuesioner juga sendiri gitu. Terus datanya juga bisa dipilah gitu. Tapi jadi platform satu besar yang kemudian itu bisa jadi bahan advokasi yang besar. Gitu.
Okay. Since the CLM consists by 7 key population network, we provide the question that has gender or data and which community you are part on, and each network they have the focal point who will do the data collection, right? So they will know all the question and they will make sure how they can get the right data, and also from the age, gender, and key population. That's it.
Jadi langsung ketemu sama komunitasnya langsung gitu. Jadi juga ada kayak laporan keluhan, ada exit interview. Jadi seperti itu untuk ngambil datanya.
Yeah, so since the data collector will be from community, so I think it will be also good to have the right data from the community itself.
Thanks, Adelia. Thanks to the 3 speakers about sharing your experience in the importance of disaggregated data. Definitely, even in the point of developing your CLM indicators, it's very important that your indicators is already disaggregating data based on your needs in the country. As we know, gender equality and gender equity approaches to actual provision of transformative and responsive healthcare services starts with having disaggregated data. And to make sure that we are able to provide appropriate services to appropriate different gender identity, sexual orientation, and different key populations as well. So maybe a few more questions. I'm trying to look at the chat box if there are very clear questions that are being asked in here. And just to acknowledge that we do have some listeners or participants coming from other regions. If I heard Estawini, I think I saw Kenya, very good participants that could actually also share their experiences in Africa region. But while we wait for them maybe to if they feel comfortable to share, I have a few follow-up questions to the other speakers. So for example, for APTN, having developed a regional tool, what were the complexities or how do you think it was translated when it comes to rolling it out into different countries? Was the tool similar and applied the same to different countries? Or what changes did they do, if there are, in specific countries that they made in developing those indicators that are more specific to their country? So maybe you can share on that.
Yeah. Actually, we have one main tools. The Transcom CDM, and but we translated into the 10 languages now for the 10 countries that we implemented and piloting the tools, in the past 3 years. And actually, most of the tools, I mean, like most of the set of the questions are the same, but we have to ensure that it's aligned with the country context. In particular, we have the country focal point, to implement, to roll out our Transcom CBM in each country. So during the training, or having the engagement with a transfocal point, we learn from them what is the specific issue, such as what happened in Nepal, right? We actually do like provider mapping to track about the availability or the providers. So we can change a little bit into that as well, to make it more localized or align with the country context. So that's what we do. And in the process of analysis, we do analyze in the country level. So in the upcoming month, I guess, actually the report is now available for the first phase of the 37 countries that we do piloting in the past 2 years. Is now the report itself is available now. And we do analyze in the country level. So and now it's on the process of designing and make it beautiful. So in the upcoming month, I think we can share on our website or any platform that we have about the country report that we obtained the data from the first phase of the Transcom CBM piloting activities.
Thanks, Nisha. We look forward to that report on the Transcom implementation in many different countries.
Actually, if you like to have if you like to get the information first, you can email to me, because we can, I think we can share the report right now, but in the Word template. But if you like to wait till like the very beautiful one, so
the designed version. So feel free to maybe Nisha to type your email in here, so that if people who are interested in a more specific trans CLM, they can reach out to Asia Pacific Transgender Network, which is good. I'm not sure if Adelia is here because I don't see the video now, but maybe I'll ask a question to Rocky. So one of your components is service quality, and we know that CLM remains to be independent from national M&E systems, for example, from national level indicators. But how do you think that your indicators complements? It remains to be independent, but they complement national level indicators that are already being monitored. How did you consider that in your CLM indicator development, that there were existing indicators, and how do you make sure that the CLM indicators complements those national level indicators?
So one of the steps that we took actually was to review existing indicators already. And then from there, we wanted to make sure that the indicators that we will be developing would be complementary to the existing indicators that there are. We have not yet produced a national-based data because we just started piloting CLM. But fortunately, CLM is adopted by the Philippine National AIDS Council as one of its information sources in terms of the overall HIV and AIDS data in the country. So we also look forward to to contribute to the national data of the Philippines in terms of the HIV and AIDS response. But I think one of the things that I can already share is during the pilot period, after we process the data, we analyze it, we package it into a strategic information. We go directly to the facilities and present the results of the CLM data. Then from there, we get to have a dialogue with our facilities and discuss how some of the issues or critical gaps identified can be addressed already at the facility level. So this is where we engage the community and also the facilities or service providers in meaningful engagement and co-create solutions using the CLM data that we were able to produce. But again, we're still in the pilot period. We have not yet experienced sharing in national based data, but we look forward to sharing that probably next year.
Thanks, Rocky. Maybe I'll just pull out the last thing that you highlighted, that when you're developing indicators, it remains to be led by communities. It is independent, but it's also important to consult, for example, the facilities themselves.
Yeah.
Because at the end of the day, they are one of your data users in improving their services. And I like the idea of, yes, co-creating the indicators, so you are able to co-create solutions at the end as well of the data collection. So thanks for reminding us as well. One question in the chat, I'm not sure if Adelia might be able to answer or would like to answer, or the other speakers would like to answer. A question is that sexual pleasure is part of sexual health and rights, or SRHR, and is considered to be important in sexual history taking and SRHR counseling. Are you also developing indicators related to sexual pleasure or pleasure meter, or are you familiar with this? And what are your thoughts on this? So let's see, who wants to respond to this first? Maybe Adelia, maybe Ika can try to translate.
Yes, I'll try to translate the question first.
Yes.
Adel, pertanyaannya, kenikmatan seksual adalah bagian dari kesehatan dan hak seksual yang dianggap penting dalam dalam anamnesis seksual dan konseling SRHR. Apakah di Indonesia kalian mengembangkan indikator untuk kesenangan seksual atau sexual pleasure? Ya.
Di Indonesia belum ada.
Okay, so in Indonesia, they don't have the indicator to measure the sexual pleasure.
No worries. How about Nisha or Rocky to talk about if you have any thoughts on this, or has it ever been discussed in your country or in your organization as well? Maybe Rocky.
Yeah, first of all, I like the term pleasure meter. But we don't have such kinds of indicators, and this is an eye opener. Maybe we can also consider having it in the future. Thank you.
Thanks, Rocky. No worries. How about Nisha?
Yeah, I think similar to other speakers that we don't have the question related to that.
No worry, but definitely I agree this is something that to ponder upon. If this is indeed a very important aspect for people to address issues of accessing SRHR services, maybe indeed there should be an indicator on that to see. And that's worth exploring. As we know, indicator development is very it's an evolution. It changes over time. It can apply to what is needed at the perfect time that you're monitoring data to address barriers and access to services as well. So let's see. One additional question in here. Let me just read it. Do you think, for the speakers, do you think it is very difficult to gather gender specific or gender related data or CLM indicators? And what do you think are challenges? So again, are there difficulties in gathering gender specific data in CLM and in developing these indicators? And what are your challenges? Maybe start with Rocky.
Yeah, I honestly don't think it's difficult. I think the challenge really is how you make sure that the group of people that you consult are, inclusive, in that all other persons of diverse gender and or other gender expansive persons are also represented during those consultations.
Thanks, Rocky. Maybe just a follow-up in that gender-related question.
Yeah.
Is it still difficult if gender-related indicators are not prioritized, for example, in your national strategic plan or in your AMTP or other national level indicators? Is it still difficult if it's not part of a national level strategic plan?
Yeah, definitely it could have negative impact because gender issues are cross-cutting. In fact, if we talk about social issues, economic issues, gender is always a consideration. In fact, it's a major issues of gender are a major contributory to different human rights violations, abuses, and lack of protections of other rights that we experience. So definitely there has to be, gender should always be considered when we are producing data and when we are, disaggregating data, reporting data. It has to always be considered. But the point is, if we don't consider them, there will always be, problems, issues, impacts, and we won't be able to record.
Thanks, Rocky. How about Nisha?
Yeah, I think as mentioned that EP10 Transcom tool is specifically used for the transgender community, right? But yeah, one challenge is that we need to ensure that all of the subpopulation among the trans community are engaged in our piloting of the Transcom CBM. We need to ensure that all trans mass or the trans youth, trans sex worker, or the trans with disability are engaged into our Transcom activities. So I think that's the challenge, because I'll be sure that the different background of the trans community will can come in the different costs when they go to receive the service at the clinic. So that's what we need to ensure during the implementation of our Transcom CBM.
Thanks, Nisha. Maybe a follow-up question. Since you work in a region such as Asia Pacific, how would you promote your Transcom tool if a country doesn't recognize trans people, maybe? What would be your recommendations or advice to push for this Transcom CBM tool if a country doesn't even recognize trans people?
Yeah, we need to have the engagement with the national stakeholders, such as now what we, because of our Transcom CBM tool piloting activity is kind of research or the survey, but we would like to advocate it to be used as the regular quality assurance activities. Not just when we we finish this period of the piloting activity and we done from that country, but no, we would like to advocate that the country partners is use our Transcom CBM as the regular activity. So so far at EP10 we start discussing with the the partner in Thailand and in the Philippines to ensure that how important of the Transcom CBM, how important of the community engagement to monitor about their services, because of no one know better than the community themselves, right? And to reflect the best thing should come from the community themselves. So yeah, and during the discussion, we not just advocate to use the trans specific tool, but we would like to ensure that all the key population are included in the CLM tools. So yeah, I think partnering or have a strong engagement with the national stakeholder would be the key activity to move forward, to advocate about our CLM activity in the regions.
Thanks, Nisha. Thanks, Nisha, for that. Adalia, just to repeat the question about, do you have difficulties or challenges in Indonesia in including gender-related indicators? And are gender-related indicators easy to promote if it's part of a national strategic plan, for example? So maybe Ika?
Hi, Rain. This is Ingrid. I'm stepping in for Ika
Oh,
for a second
sorry.
while she's having a quick toilet break. So Mbak Adel, pertanyaannya adalah kira-kira apakah ada tantangan untuk membuat indikator yang spesifik terkait dengan gender di Indonesia, dan apakah kalau misalnya dalam RAN, jadi rancangan aksi nasional HIV itu ada fokus ke gender, apakah itu lebih mudah untuk memasuki indikator terkait dengan gender?
Oke, saya coba jawab. Sebenarnya kalau untuk gender kami memang ada hambatan ya, karena kalau di Indonesia ini saat ini kan banyak banget nih pengakuan gender gitu ya. Tapi karena memang saat ini opsi kami punya 3 gender, jadi kami tetap memasukkan isu gender di dalam rencana kerja strategi kami gitu. Nah, memang agak sedikit kesulitan ketika kemudian kami harus melakukan sosialisasi nih tentang gender, apalagi kalau langsung kalau ke layanan atau apa itu is oke ya, tapi kalau misalnya sudah bersentuhan dengan masyarakat gitu, itu yang masih agak masih agak kesulitan. Tapi saat ini di Indonesia sendiri udah banyak tuh kelompok-kelompok teman-teman keberagaman gender. Jadi saat ini sih sudah tidak terlalu sulit lagi menurut aku. Kalau untuk itu.
Oke, jadi untuk masukin indikatornya juga lebih mudah karena sebenarnya di Indonesia yang diverse secara gender itu juga udah lebih diakui gitu ya.
Udah lebih terbuka merekanya juga gitu, teman-temannya.
Okay. Okay, so I will translate. Thank you, Mbak Adel. So Mbak Adel said that in terms of gender, yes, there are challenges. However, especially because OPSI, her organization recognizes the 3 genders, which adds the challenge, especially when it's in creating the socialization part, socializing the, having the 3 genders and disaggregating with these 3 genders. From her experience, socializing to the services are still okay, it's still doable. The harder part is to the larger public and to other stakeholders. That is a bit more challenging. However, she also noticed that in Indonesia, there's more and more openness and recognition of the diversity of, sexual orientation and gender identity. So it is kind of a work in progress, and it's in her view getting better. Over. Thank you.
Thanks Ingrid for the support in the translation, and thanks Adalia for that insight as well. I see a couple of questions in the chat, and just a reminder that we do have like 15 minutes more for our Q&A. Is there anyone aside from what I see in chat who actually wants to speak, or maybe to ask your question, or maybe to actually share an experience in your country in developing CLM indicators, especially including gender-related indicators and social structural barriers indicators? Let's give a few minutes to see if I see a raised hand that would like to share, so that we can also hear from other speakers on joining this call. Let's see. Harry, raised his hand. Harry.
Okay, thank you, Rain. Thank you, Rain. So I just have a question for Micha. I'm just very curious about how, because you said that you already you already collected all the data from the from country through your CLM tools, and then I just wondering how you're analyzing it, the process, the analyzing process of the data, and then also how you're going to use the strategic information coming from the CLM that you can make sure that it will be used by the trans community, the country levels, and then try to push some policy change in the country, in that country as well. So thank you. That's my question.
Yeah, thank you, Harry. So yeah, from the data that we obtained, we analyzed, the data was analyzed by APTN. Actually, the Transcom CVM is like a scorecard. Some of you may have seen that. So yeah, we took this score, we analyzed from the score that evaluated in each question. So then we will see what is the gap, what is the challenge, or whether there are room of improvement for each healthcare providers. So then so the information will be captured and reviewed, and probably need further clarification if needed. So then as I mentioned that we are going to produce the country report, right? And yeah, from the dissemination of the report, I think the country partners can use this report as a baseline to advocate with their policymakers or the government in their country. So yeah, we haven't been proceeded into that level now because of the report is now finalizing. But yeah, as discussed among some of the partners in Thailand and the Philippines, we will use the data or the information obtained from the piloting activity to be used as a baseline of the quality of the service of the transgender health package in the country. And then we see what is the challenge, what are the gaps that the community and all stakeholders can bridge and address the gaps that are found from the reports. Thank you.
Thanks, Nisha, and thanks, Harry, for the question. Indeed, we look forward. I think many CLM mechanisms always looks forward to that point. We sort of say endpoint of really how this data translates into advocacy and how it improves services or changes to programmatic priorities or even actual policy changes. So we look forward to how this Transcom tool leads to that effect. So I have a raised hand from Nikos.
Hi, everyone. I don't have a question, but I just want to commend our speakers and our moderator, Rain, about a very sophisticated discussion around gender inequality and other forms of social inequality and how CLM needs to capture this. So it's really a privilege to be listening to all of you. Thank you.
Oh, thanks. Thanks for that affirming message from one of our colleague as well. I just see in a chat, Matthew shared some useful tools from their CLM toolkit from the sustainability of key populations in Asia. Maybe just a quick, Matthew, can you speak quickly about this reference tool just for everyone's information as well and how it can be useful if you are available?
Yes, I'm happy to. Thank you, Rain. So the toolkit was developed before I started, so I can't speak too much to the development, but in terms of the actual content, we use the AAQ framework. And so there are 8 CLM indicators, and there is a data collection form. So that data collection form can be used to collect those 8 indicators. So we have one on acceptability, affordability, and all of the AAQ questions. And then we also have some on stigma and discrimination. And then we also have 5 follow-up indicators. And so if people have experienced serious incidents or stigma and discrimination, there's actually a process of following up. So a trained, case manager or focal point from a key population organization would then do that follow-up. And so we're in the process of piloting that in 3 countries, and then the findings should be ready in the next month or so. And then hopefully over the next year, we'll update and revise that toolkit based on the findings from Bhutan, Sri Lanka, and Mongolia. And I think we have some colleagues who have been involved from Bhutan who have already shared on previous webinars of their experience. Thank you, Rain.
For sharing that. Indeed, there are a lot of toolkits and guidance documents also specific to CLM indicator development, and key populations or groups who are leading CLM should maximize and utilize these resources, but to remember that these are guidance. These are not cast in stone. You should use this as reference and make it contextualized to the needs of your country, but definitely use those resources as they are developed. I do have supposedly an anonymous question, but it's not anymore anonymous. So now, the question is, whoever it might be relevant to any of the 3 speakers, how can we make sure that there are indicators from adolescent key populations, young and adolescent key population, and PLHIV under 18 in their country? How do you consider that discussion? Even if you're not answering the question, maybe how do you consider that discussion of indicators that also includes access to services of adolescents, key populations, PLHIV under 18? Maybe we can start with Rocky. I can see you're thinking.
Yeah. So when we were developing our indicators, we've invited some representatives from the young community. We do collect age, and I mean, the point is we don't have very particular indicators that would, address particular concerns of young people at the moment. And our indicators are also will be subject for evaluation after our pilot period. We will definitely consider how we can improve them further. But what we do now is we make sure that all questions are relevant to different backgrounds, regardless if these are young people who are accessing services or older people who are accessing services. We get their age just so we can establish also a trend or a baseline on which are the kinds of needs that are for a particular group of people.
Thanks, Rocky. How about is trans people below 18 considered as an indicator in the Transcom CBM tool, Nisha?
Yeah, as Rocky mentioned, I think we would like to engage with the trans community in every background. So I think we have some indicators that included the trans youth in our Transcom CBM tools. So I think from our principle of our Transcom CBM that we would like to engage all of the background of the trans community. So trans youth is one of the subgroup subpopulation that we engage into the trans community.
Thanks, Nisha. Maybe to Adelia for Indonesia. Someone could translate. Do you have indicators that also caters or could reach out to key population, PLHIV, young girls that are below 18?
Please help the translator.
Who do we have here? Do you have Ika or Ingrid?
I'm a translator.
No worries.
I'll help translate. I'm not sure if Ika is fine. So, Mbak Adel, pertanyaannya adalah, my pleasure. Pertanyaannya terkait dengan indikator untuk remaja dan anak muda yang di bawah 18 tahun. Kira-kira apakah ada indikator ataupun pertimbangan untuk mengumpulkan informasi dari populasi remaja ini? Soalnya pastinya ada pertimbangan-pertimbangan khusus ya. Kira-kira dari opsi atau Jarnas lainnya ada proses pertimbangan itu nggak?
Sebenarnya kalau pertimbangan pasti kami punya pertimbangan gitu ya, karena kan bukan hanya inti muda yang kemudian anggota atau konstituennya itu remaja di bawah umur 18 tahun banyak, tapi ternyata juga pekerja seks, ada pekerja seks yang masih di bawah umur 17 tahun, bahkan kemarin kita dapat yang umur 14 gitu ya. Dan itu pun terjadi di pengguna jarum suntik, di teman-teman perempuan yang hidup dengan HIV gitu kan. Jadi itu memang kami pertimbangkan, tapi atau mau dijelaskan dulu ya kepanjangan.
Okay, sure. So for the first part, she will continue later, but the first part is yes, they definitely considered it, not only because Inti Muda, which is the national YKP network, is part of the 7 national networks that are part of the CLM, but also that they actually see a lot of these adolescents and young people being part of all the other communities as well. So from the sex workers, the people who use drugs, women living with HIV, within those communities, there are many from adolescents and also young people. Mbak Adel?
Kenapa kemudian ada 10 indikator yang digunakan di Indonesia, CLM-nya, tapi kami ambil di nomor 2 tentang pemantauan layanan. Karena isu kami sebenarnya sama ya, dari 7 jurnas itu ada kayak kayak lingkaran gitu ya, sama-sama dapat stigma, dapat diskriminasi, dapat pembedaan di situ. Nah, kemudian kenapa kami temukan bahwa ternyata akses layanan itu sebenarnya harus diberikan pada semua populasi kunci dengan semua umur gitu ya, dari semua kalangan gitu. Nah, itu yang kemudian kami dorong supaya ada perubahan kebijakan nih di rumah sakit. Seperti kan kalau kita mau tes IMS misalnya, kalau remaja itu agak kesulitan karena dia harus menikah, harus punya pasangan, kok sudah melakukan hubungan seks gitu ya Kak. Nah itu yang coba kemudian kami temukan, jadi banyak temuan di informasi itu, juga ada di teman-teman pekerja seks lah, itu yang kemudian kami pantau bersama, kami dorong supaya remaja pun punya hak yang sama untuk mengakses layanan kesehatan gitu, diperlakukan sama lah gitu, tanpa pembedaan usia sebenarnya.
All right, so because of that, so among the 10 indicators that they are using and the monitoring in Indonesia, the second one is about monitoring the quality of services, right? And the development of the indicators were making sure that these are common challenges that all the communities are facing. For example, stigma and discrimination and other challenges that all of the communities face. Because of course it is driven by the principle that all services need to be given of high quality for all communities and also for all ages. Some findings from the CLM in Indonesia show that adolescents and young people are experiencing, let's say, additional challenges and additional barriers, questions about their behavior, about their whether they're married or not, etc. And so these are the kind of findings that they use in their advocacy, especially to push for everyone of all ages, of all communities to be treated equally and to receive high quality care. I hope I translated that correctly, Mbak.
I think you did well. Thanks, Ingrid, and thanks, Adelia, as well. I think a point in here is that as much as we are discussing gender-related CLM indicators, it's equally important to have age-related indicators, because we need to make sure that we cater to young adolescent and young people to make sure that services are accessible to them as well, despite limitations and barriers for them to access services. And indeed, that is very important. I do have 6 minutes and for our Q&A, and I see a very active participant. Maybe I can call the person to share the comments related to this. Prao Chan from Nepal. If you're available to share or to speak or to share your comments or your last question about how important it is in Nepal about young people using drugs, I think you mentioned in here. Are you able to speak and share?
Sure.
Yes.
We have been facing challenges for so long, and we through the youth lead support, like we have even developed the normative guideline, uh, focusing on young people who inject drugs. The main thing is that we have the policy that is very restrictive and more traditional, where it does not spell out properly whether like the harm reduction program should be provided to the people who are less than the age of 18, because the data shows that people start injecting at the age of 12 or so, right? And by the time they become adults, or by the time they reach 18 or something like that, they have all kind of major problems related to health, like the vein collapse, did vein thrombosis, abscess, whatnot, right? um, uh, and I think the CLM as an approach should also need to have some indicators related to this segment of population, prioritizing it where we can actually make the action agenda that comes from the CLM for the future advocacy, so that the program focusing to this segment can be brought up, or even we are writing a grant. We are up now. It is the time for the Grand Cycle Fund, Grand Cycle 7. So I think if that sort of things come up and the proper advocacy can be done at this point of time during the consultations, maybe some focus will be given to these populations, where specific service focusing to them will be in place. Thank you very much.
Thanks for sharing that and the experience from Nepal as well. And I would just point out that it's very important to also include issues of people who use drugs and even in harm reduction programs, and that's because it's very relevant even to young people. So thanks for sharing that, and it's very indeed important. So we're already running out of time of the Q&A. So I think this has been a very fruitful an hour and a half of discussion that we had so far. Before we proceed with the Menti question for all the participants to share, just to remind that what key points that we are getting from the discussion so far is that it's very important to remember that community-led monitoring indicators needs to be decided on and to be led by communities themselves. The context of consultations, a diverse level of consultations are needed to co-create these indicators, that CLM indicators are very flexible and adaptable, and that all these guides that you're using as reference, use them as guides, but also consider the context of what you're looking at. Beyond service quality monitoring or CLM, we can definitely include other structural and social barriers. We need to include gender-related barriers. We need to include S&D. We need to include GBV and SRHR services as well into the mix. And what we need to remember is both gender-related and age-related indicators are equally important to be included. And beyond gender disaggregation, we need to look at the broader gender issues in the country that affects and becomes a barrier to the services. I think that's our clear takeaways from the messages. So given that, I will give the floor first to Sarah to administer the Menti. And while the Menti is being administered, I will be asking the three speakers to have a final message and then takeaway message. So Sarah first.
Hi everyone, good afternoon. I'm Sarah Thapamagar from ICWAP, working as a human rights and gender officer. Before we start, can we have a group picture? Can you please all turn on your cameras? Like we want to see your beautiful faces.
Should the participant also do that as well,
Yes.
Sarah?
Yes.
Okay then.
Oh, hi everyone. Okay. You all look so beautiful. Oh my gosh. Okay, let's go. I will take this picture. So with a big smile. 1, 2, 3. Wait, again.
Bernice, are you there? Sorry. So that we can see everyone's picture on the photo. Okay, thank you.
Okay, 1, 2, 3.
So here we go CLM.
Okay, again. 1, 2, 3. Thank you, everyone.
Thank you, Sarah.
Thank you very much.
Okay, now it's drawn for our Mentimeter. I would like to request Nikos. There is also a QR code you can scan, and please put your answer here, that how can key population communities meaningfully engage in developing CLM indicators? If you're having any difficulties, please let us know in chat. Hi, you can scan this QR scanner, which has been shown in the screen. Okay, now we can see the answers. So obviously, like the one of the discussion during this webinar, we have heard a lot of perspective of community that need to be included for the meaningful engagement in developing CLM indicators. And also the community members should be engaged from the start, that is right. And also the active involvement of perspective of community members. Yes. And also full engagement, and we can also say the meaningful engagement of all the key populations, which we are discussing during the webinars, that our community members should have full rights and full engagement during the CLM development of the CLM indicators for the meaningful engagement of our key populations. And also, yes, one of the main thing is the cross-learning from, like in Nepal, we are also implementing CLM, and we also got opportunities to learn from different countries through webinars. Yes, and also the active involvement of our community members. Also create our own indicators, which I like it. So actually, it's really, really good that we are not only limiting our CLM indicators in services, but beyond that. For example, we just heard that different countries are also expanding their indicators to policy labels, and also in the PLHIV stigma related indicator. That is nice. Okay. And also one of the major point, which I also think is the capacity building of our community members for them to really understand the CLM, because it's very important for our community members to know about CLM and how they can be meaningful and full representation of our community members. So can we go for the next question? So we also have the second question. So the second question is, what are the specific structural and social barriers affecting health services that needs to be included in CLM programs? Mhm. Okay, gender-based violence, yes. Gender and age, yes. Economic status, yes. Thank you for answering. Socioeconomic part, yes. Diversity population, IPV, yes. Stigma discrimination, free access, SRHR, yes. Thank you for the recommending. So free access, IPV, SRHR, safe and convenient, insufficient services of, okay, yes, the language barrier is one of the issue everywhere. So yeah, health system, right? I think this is the very good platform to recommend all these things, that when we are going in the next phase, then we can also take this as a recommendation that what we need to add, especially social barriers that are affecting health services and that need to be included in CLM programs. I think this is a very good recommendation for our 7 Alliance and also the other countries that have been joining in this webinar. Thank you everyone for sharing your views. And now I would also like to request Ren for the further procedures.
Thanks, Sarah, for facilitating that mentee inputting session coming from the participants. Very useful information and reinforcing what we have been discussing through all the session. We have 7 minutes, but I want to ask all 3 speakers for your maybe final key message, especially in terms of what would your key recommendation be to ensure meaningful community engagement in developing CLM indicators. So maybe I would start with Nisha first.
Yeah, so I would like to say that, meaningful engagement is really meaningful, even though you work with specific or particular communication, but, with the different background, with the level of the diversity, you need to ensure that everyone are engaged into the CLM activities, so that we can learn that, yeah, we get the input, we learn the challenges from everyone, and we can address everyone issue. So yeah, thank you.
Thanks, Nisha, and thanks to APTN as well. Can we ask Adelia? Is Adelia here? I can't see Adelia, sorry. Adelia?
Yeah, I'm here again.
Yes.
Could you please repeat the question again?
The
Sorry.
question is, what would be your final key message or recommendation to ensure meaningful engagement of communities in CLM indicator development process?
Oke, Kak Adel ada nggak pesan terakhir, key final message untuk bagaimana memastikan keterlibatan key population dalam pengembangan indikator CLM dan juga rekomendasi.
Oke, kalau untuk memastikan keterlibatannya, sekali lagi memang CLM ini kalau di nasional itu ada Jarnas, jadi ini harus dipastikan harus benar-benar ke daerah. Kenapa kemudian kami ada modul sama panduan, jadi kami teman-teman di Jarnas akan memastikan bahwa panduan sama modul ini akan digunakan di daerah dan melibatkan teman-teman mulai dari penentuan isu, terus penggerakan komunitas sama di saat pengumpulan data sampai dengan pemantauan serta advokasinya. Itu memang harus benar-benar dilakukan. Kalau pesannya sebenarnya sama ya Kak, karena nasional atau nasional itu bisa kuat ketika teman-teman daerahnya juga kuat gitu jadi ya. Jadi pesan saya adalah kemudian kita semua harus sama-sama menguatkan di daerah, di distrik, baru kemudian kita bisa mengadvokasi yang di atas gitu. Karena sebenarnya kita juga punya dasar gitu ya. Dasar kita yang di daerah itu adalah kekuatan kita sebenarnya untuk isu-isu, untuk mendorong advokasi. Jadi daerah sama nasional itu harus sama-sama punya kerjasama yang baik, saling menguatkan. Seperti itu sih kalau di CLM pesannya.
Makasih Kak Adel. So from Adel's point, the community must be the leaders of the CLM, and also as the national organization, they need to capacitate their network in the provincial level so they can equally engage in the CLM process, and also as the national network, the 7 key population organization really need to ensure that all the members are included in the CLM process and also consultation. Thank you, Ren.
Thanks Adelia, and thanks to Opsi, and thanks Ika for the translation, and Ingrid earlier on. So for our final message from the speaker, Rocky.
Thank you, Ms. Rain. The discussion is really good, and for me, I think we have to be, of course, intentional about how we ensure meaningful engagement with the communities that we serve. And that's beyond developing indicators. For example, and I think this may be context-based, it may not necessarily be applicable to all of us, but I think I absolutely believe that if we want CLM to achieve its purpose, we have to make sure that the power to lead, the power to identify best practices and critical gaps, and eventually co-create solutions with our duty bearers remain practiced to have meaningful engagements between our KPs and other stakeholders of the HIV and AIDS response.
Thanks, Rocky. Thanks for all the speakers. Can we give our speakers a virtual snaps or claps for them? Let's share some love to our wonderful speakers who has been speaking for an hour and a half as well. And just to a good message is really like CLM indicator. It's all about co-creating indicators to co-create solutions. Definitely, that's what we need to remember as well. And with that in mind, thank you for this session. I would just give the floor to Harry to give us his final summary, conclusion, and reflections. And thanks for, of course, joining this session now today. Thank you, Harry.
Thank you, Rain. So, well, finally we did it. The 4th webinar in a row, last year and this time. So I think by the time now, everybody try to clearly understand what CLM is, for those who are working on the project management, usually we know this kind of a slogan. They say, one true test of leadership is ability to recognize problem before it become an emergency. So it's quite clearly on that sentence, they put community at the center and forefront, and also make sure there is also showcasing the leadership of the community. So this should be embedded in the CLM. So during this last webinar, the capacity building, we learned about how we create indicators using the framework of indicators when we start to, step by step. Now, in today's webinar, we heard about a community across the board, especially sex workers and trans, are involved in the CLM, and we as part of the community should also give them a chance to have more space in showcasing their leaderships, since we all agree with no one left behind. Gender lens in the spectrum of inequality of CLM, according to Dom, that is clearly the community is the best way to measure about this issue, since there should be gender disaggregation data in CLM. The indicator from gender framework on CLM, which is AAQ, should undertake a consultation with the community. This shows clearly that CLM is owned and led by community to ensure what the indicators it look like. Lastly, the one thing that I'm going to try to take note here is indicator from CLM should be complementary to the existing country indicators. This coming from Rocky. Thank you for that, panelists. Give a round of love. Pull the screen with love to all the panelists. And okay, so we come to the end. So to next webinar is all about young people. We want to make sure young people is fully engaged in the CLM. Many countries in these regions, the young people is not have a lot of voice in terms of CLM. So next month we're going to make sure that CLM will be focusing on young people. Go back to you, everyone, and thank you so much, and thank you so much, Rain, for the fabulous moderator, Sarah, for being brilliant work on Menti, panelists, participants, everyone. I love you. Bye, everyone.
I love you too. Can we share one love for Rain, please? Everyone, do the emoji. Love. Thank you so much. Thank you. Bye. See you in next webinar.